Mayung, thank you very much for that very kind introduction, and good morning, everyone. I have to say, thus far, I've found the program to be extremely educational. I've learned quite a lot yesterday. So today, my remit is to take you through the imaging of chronic thromboembolic disease. I'm going to start off with the current guidelines for CTEPH. We will look at the histology, the pathology of CTEPH before we actually look at the radiology, because I truly believe it's easier to understand the radiological features of CTEPH once you understand what's happening at the pathological level. We will, whilst we look at the spectrum of these signs and on radiology, clarify the strengths and limitations of the different imaging modalities. And finally, I'll touch on the few technological advances that may be relevant in the future coming years. Now, the first thing to say is you've got to think of the diagnosis in order to make the diagnosis. Now, this may seem relatively simplistic way of approach, but one of the problems that we have all over the world is the diagnosis is not being made accurately. And the reason for that is we have all the imaging modalities, but we are just not used to making the diagnosis. And as Ash mentioned before, it's not just it's a rare disease, it's an under-recognized disease that's a particular problem. Now, we know from all the literature that about 25 to 30% of patients who have CTEPH do not necessarily have a history of previous pulmonary embolism. The second point is the absence of venous thromboembolic disease should not preclude you from making a diagnosis of CTEPH. There needs to be a high index of suspicion both amongst the referring clinicians as well as the imaging specialists who are looking at the images in order to get the right diagnosis. We know that there is a period of delay for up to about 14 months before patients get the appropriate diagnosis. And so my remit generally is to see what can you do to speed up the diagnostic process, and there are in the guidelines now that are coming out, certain things that you could do. And one of the main features is make sure that you have a systematic follow-up of patients once they've had a previous PE. So the evaluation of CTEPH is a threefold process. The first thing is you have to suspect CTEPH. In whom would you suspect CTEPH? Predominantly anybody, basically anybody who has got a history of pulmonary hypertension. You've got to make sure they do not have group 4 disease, which is CTEPH. You should also be suspecting CTEPH in all those patients who have got unexplained dyspnea. The next thing is once you suspect the disease, you've got to screen for it. And what do we have for screening? Well, echocardiography is the frontline modality for looking at the right heart. The next thing you can do is VQ scan, and I'm going to show you why VQ scan is the preferred modality for screening amongst all of the armamentarium of diagnostic modalities that we have to hand. Finally, once you have made the diagnosis, you've got to confirm it, and the confirmation can be whatever you have at hand. So it can be a CT angiogram, it can be an MR pulmonary angiogram, it can be a catheter pulmonary angiography. You have to do 3 things. You have to A, diagnose the disease, but you also have to localize the disease and assess the suitability for appropriate treatment. Okay, so these are the guidelines that we have. The latest guidelines, this is from 2016. The next guidelines are going to be coming out from NEAS in 2018. Now, the first thing is echo. Okay, so what happens if the echo tells you there is no pulmonary hypertension? In this guidelines, they tell you stop. There is a probably in there, and the reason for that is we are now finding that there is a group of patients who have chronic thromboembolic disease on imaging, but they do not have pulmonary hypertension on echo. Okay, so this group of patients, the chronic thromboembolic disease patients, have not been dealt with in the current guidelines. That's the white elephant in the room, and that's the bit that's going to be really addressed in the next set of guidelines in 2018. So if for the moment we park that group aside and go on to look at the patient who has been diagnosed to have pulmonary hypertension on echo, what do you do next? And the simplest and the easiest thing to do is to do a VQ scan. And what you're looking out for in a VQ scan is a perfusion defect, which is not matched by a ventilation defect. And when you see that, you then plug it into the algorithm for CTEPH. And that means that you go on to do a cross-sectional imaging. Usually it's a CTPA. In those patients where the perfusion scan is completely normal, You are not dealing with group 4 disease of pulmonary hypertension, i.e. you are not dealing with CTEPH and that group of diseases which cause obstruction within the pulmonary vasculature, and therefore you're going to put this patient group in a very different diagnostic algorithm. Once you've confirmed that what you're dealing with is CTEPH, you've got to characterize the disease, and you can do it, as I already mentioned, with MR, CT, or pulmonary angiography. But remember, CTEPH is not just a disease of the pulmonary vasculature. You've got to look at the underlying right ventricle, and in order to do that, you can opt to do echo or you can opt to do MR, and MR is the gold standard. Even today, with all of these non-invasive imaging modalities, right heart catheter is an integral part of diagnosis. You need to know what your pulmonary vascular resistance is before you can decide what's the most appropriate treatment, and therefore you cannot dispense with right heart catheterization. Okay, now the next few minutes I'm going to be touching on pathology, and you just have to bear with me because the radiology makes so much sense once you understand the pathology. So the first thing that happens when you have acute PE at microscopic level is laying down of the so-called lines of Zahn, which is platelets, red cells, and fibrin gets deposited within the blood vessel. This is the easy bit. This is the bit that you saw yesterday. All the CT scans where you see the acute thrombus, the central area of low attenuation on the CT scan, is because of this acute thrombi. Majority of the patients, and by majority, as Ash mentioned before, about 95 to 96% of patients will resolve that thrombus either because they've been put on anticoagulation or thrombolysis. Whatever it is, the majority gets better. A small proportion, and we think that proportion is anywhere between 3 to 5%. A recent meta-analysis that came out last week suggested it's about 0.5 to 2.5%. They go on to develop CTEPH. So what happens at a microscopic level is the thrombus gets organized. And by organized thrombus, what I mean is the thrombus gets into this formation of a vascularized connective tissue. The next step in the CTEPH progression is they go on to recanalize the vessels. And by recanalization, what I mean is they form these vascular channels within the occluded vessel. The third step is once you get the recanalization, the organized connective tissue becomes all these intravascular fibrotic mesh and bands. Finally, you get the so-called intimal thickening, medial hypertrophy, and the plexiform lesions that Ash mentioned in his last talk. So, if this is the natural evolution of pulmonary embolism, what are we going to see on imaging? And this is just a Noddy diagram that I published, I think it was a couple of months ago. And very simply, what you have is acute thrombus occupying the vessel. It can completely go away, or it can completely occlude the vessel. So you can have complete occlusion, or you can have partial retraction. With partial retraction, you end up with the formation of recanalized vessels, webs and bands, and stenosis. So I'm now going to show you all of this on imaging, and it's just going to be one of these 5 things that you will see. And before we look at the anatomy of this, just one more thing to say. You've seen this many times before. This is acute thrombus, okay, acute PE. In contradiction to the specimen that you see in chronic thromboembolic disease, where it's this thickened fibrotic mesh of tissue. So, if this is how different these specimens look at pathological level, it makes sense that the radiology of acute PE is very, very different from chronic thromboembolic disease. When it comes to choosing which imaging modality you want to choose, you're going to be spoiled for choice. But the simplistic way of approaching this is you need an anatomical modality and you need a functional modality. Which one you choose, I will leave it to you depending on what equipment you have in your institution and what expertise you have in your institution. Most places will choose a VQ because that's the test which has got the highest sensitivity. And San Diego, where they do plenty of these operations, pulmonary endarterectomies, conventionally has taken the catheter pulmonary angiography as the gold standard. Some places, some high volume centers, and mine is one of those, we have chosen CT as our main modality because that's a test that's commonly done, and we see enough of these cases and feel comfortable in making our diagnosis based on the CT. We also supplement it with MR, both in the form of MR pulmonary angiogram as well as for the right heart assessment. Now, okay. So, one important question that people ask me is there anything that you can use to predict which group of patients will go on to develop chronic thromboembolic disease if you look at their CTPA of the acute stage? And the answer to that is not really. But this is a very important paper. It was practically a landmark paper which looked at clinical prediction of CTEPH following acute PE, and only one thing came out for imaging, which is if you have right ventricular dysfunction at the time of your acute PE, either on CT or an echo, you are more at risk of going on to develop chronic thromboembolic disease. Now, VQ scintigraphy, ventilation perfusion scintigraphy, is a modality that's received a lot of negative publicity, and that's because its usage in acute PE is fraught with difficulties. And if you've been here before yesterday, you would realize all this PIOPET criteria is not easy to follow, okay? In the context of chronic thromboembolic disease, the role of VQ is very, very simple. It's binary. All you want from your VQ scan is the Q scan positive or negative? By positive, I mean, do you have perfusion defects that are not matched on ventilation? If the answer to that is yes, and I don't want to know how many perfusion defects, is it bilateral or unilateral, is it segmental, subsegmental, all I want to know is there a perfusion defect, yes or no? If the answer is yes, I want to go down and look for chronic thromboembolic disease. If the answer is no, it's unlikely that the disease process that's contributing to pulmonary hypertension is chronic thromboembolic disease, and my diagnostic pathway is completely different. There is one note of caution, which is patients who have had acute PE and have had a VQ scan where you show they have got perfusion defects, we know that they take some time to clear these defects. Up to 50% of patients will have persistent perfusion defects even at 6 months, and another 40% of them may have it even up to 11 months. So unless you've had a baseline VQ, it's very difficult if you're first given a VQ 6 months down the line to say how many of these defects are persistent from the initial event and how many of them have happened in the interval between the first event and the time of presentation. Now, these are 3 different cases. All of these cases give you perfusion defects. The problem that you have with VQ is, based on the VQ scan, I cannot tell you which one of these patients have got acute PE and which one has got chronic PE, because a perfusion defect is very simply a perfusion defect. There isn't that many difference between an acute and a chronic perfusion defect. The next thing is, you cannot use VQ for prognostication. I cannot tell you based on the VQ if the disease is proximal or if it's distal. I cannot tell you if the disease is predominantly occlusive or if it's secondary to web disease. And I certainly cannot tell you what is the severity of the disease. And the reason for that is the Q scan is done by injecting macroaggregates. These are tiny particles, and when I inject them, if you've got a vessel that is partially recanalized, these small particles can get through these webs and the partially recanalized vessel. So you can have a very underwhelming VQ, but the pulmonary vascular resistance can be really high. So you really cannot use just the VQ scan to tell you what is the underlying severity of the disease. There are some false positives with VQ. This is an example of a complete occlusion of the right lung on the Q scan. If you look at the MR, you can see that there is nothing happening in the right lung. There is intact vasculature in the left lung. CTEPH is a bilateral disease, although the manifestations can be predominantly unilateral. But when you see completely occluded lung on one side and nothing at all on the other side, you should have to think outside the box. And one of the conditions that can give you this is vasculitis. If you suspect vasculitis, the best thing you can do is to go on, apart from doing your biomarkers, is to go and do a PET scan. And in this patient, the pulmonary vasculitis was quiescent and wasn't taking up the FDG, but you can see the aorta taking it up. This is systemic vasculitis with pulmonary involvement. Another case where you can have a false positive VQ is there is a big defect, and it's practically a lobar defect, but if you look at the volume rendered CT image, what they've got is fibrosing mediastinitis. So just remember, not all perfusion defect is due to CTEPH. A sarcoma will also give you a perfusion defect. So a perfusion defect is good enough for you to say, I need to look for CTEPH, but you cannot just rely on it. You need to go on and do cross-sectional imaging. The strengths of the VQ scan are A, high sensitivity, B, less radiation dose. Although if you listen to the talk yesterday, we can now match CT doses less than acute scan, and it's not contraindicated in patients with renal impairment. But, and this is a real issue, there are a lot of institutions who do not have access to a VQ scan, so it tends to remain an underutilized test, and also there is a lot of confusion with the reporting of acute PE versus chronic PE, and I strongly urge you to speak to your nuclear physicians and say, I don't want the pipette criteria to be applied for my chronic thromboembolic disease. I just want a binary yes-no answer. Now, these are the angiographic features of CTEPH that you're going to see on imaging. I have to say, as with everything else to do with the disease, the description of this also came from San Diego. Bill Auger, who first described it in the 1990s based on catheter pulmonary angiography. But what I'm going to show you is the same finding in catheter angiography, CT and MR. There are 5 findings to look out for. The first one is complete occlusion, and that's self-explanatory. The vessel does not exist. The second thing is the presence of the so-called pouch defect, the convex defect that the arrow is pointing to. That's where the thrombus comes to an abrupt end, and you may have a small trickle of contrast beyond it. The next feature you're looking out for is stenosis, which is just narrowing of the vessel. And as with narrowing anywhere else in the body, when you see narrowing, you will see post-stenotic dilatation. So the vessel is small in caliber and then it becomes bigger in caliber. The presence of intravascular webs, basically these are hypolucent structures within the lumen of the vessel. They can be branching and linear lucencies. With MRI, it's easy to see because you can see that there is a web. Catheter angiography also shows you the web, and that is the lucent area that the arrow points to. But the important thing is, with MRI, you've got the option of rotating the data set, so you are looking at it in 3 dimensions. With pulmonary angiography, if you just do one view, unless you are absolutely perpendicular to the lesion that you are looking at, you may miss it. So it's extremely important, if you are relying on catheter angiography, to do 2 views. An AP view and a slight oblique view. A true lateral may not help, but an oblique will definitely help. Intimal irregularities, very simply, is the thrombus is eccentric because it gets marginalized, and the longer the thrombus has been within the blood vessel, it can get calcified. The intimal irregularities are better seen on CT and MRI compared to catheter angiography, because just remember, just like the coronary circulation, a catheter angiography is a luminogram. It doesn't tell you, it tells you lots of things within the lumen, but doesn't tell you that much about the wall of the vessel. This is MR, and again, depending on the sequence that you use, you will see more of what you want to see. Now, if I just go into this, this is how we use MRI. So you can use MR, you single injection, and you look at the dual circulation. And by dual circulation, I mean pulmonary. And then you wait for some time and you look at the systemic circulation in order to look at the bronchial collaterals. Of course, MR angiography is very well established, and in our institution, we use it to supplement CT to look for operability assessment. And the temporal resolution of MR versus catheter angiography, I get asked this all the time, and the truth is, when the disease is proximal, both modalities are very complementary, but where we are dealing with a distal disease, the temporal resolution of catheter angiography is much, much better. So you're going to see the distal vessels, the subsegmental vessels in more exquisite detail with catheter angiography compared to MRI. However, if you look to see which modality tells you the proximal extent of the thrombus better, It's really true that CT and MR will give you much more relevant information about the proximal extent of the thrombus compared to the catheter angiography. Now, for pulmonary angiography, a few years ago, people were saying, what with the advent of CT and MR, do we really need catheter angiography? And the answer to that is, if you had asked me 3 years ago, I would have said, no, we don't need it. But right now, yes, we do need it for the purpose that people have gone on using this technique to do balloon pulmonary angioplasty. And you're going to hear more about this later today, so I'm not going to labor on this. Another thing that you would use imaging for is to look at the underlying perfusion defect. So these defects look relatively the same, whether you use catheter angiography, a VQ scan, or an MR. Just a word of interest on that pulmonary angiogram. When you're doing the angiogram, you need to keep your foot on the pedal long enough, not just to see the arteriogram, but you also need to look at the venous return to that particular segment of the lung. And that gives you a lot of information. So it's important that you keep imaging long enough to look at the venous return. Now, on the CT, this was something that was mentioned in the radiology talk yesterday. So this is very important factor to look out for mosaic attenuation, which is this geographic area of black and white lungs. Black lungs, reduced perfusion. Gray lungs are the areas with preserved perfusion. Now, this again is a very important paper. It came out in 2014, but people are starting to pay more attention to it. And what this was a paper that was, it's an epidemiology paper, and they said 1 in 25 patients with acute PE go on to develop chronic thromboembolic disease. Now, that wasn't the surprise. The surprise in this paper was they found the so-called acute PE in some instances were not really acute PE, they were really acute on chronic PE. And the reason why this has become very relevant is when you're using all of those treatment modalities that were discussed yesterday, are you going to do a thrombectomy, are you going to do a catheter-related thrombolysis? All of that is not going to work if the condition that you're dealing with is chronic thromboembolic disease, and what you have is actually an acute insult in somebody who's actually got chronic disease, and therefore it's very important that you don't get misled by the diagnosis. This is a real-life case where a patient presented acutely, a 70-year-old woman, and you can see that there is thrombus in the right main pulmonary artery. There is also thrombus within the vessel, which looks relatively acute. On the first thing, I would have definitely said chronic, but there is definitely an acute component. But I would urge you to look at some of the other parameters. If you look at that right ventricle, it's not just dilated, it's hypertrophy. You're not going to get right ventricular hypertrophy with acute PE. Also, you do not get bronchial collaterals in acute PE. So the minute you see bronchial collaterals, and these are hyperplastic vessels more than 15-20 millimeters coming from the thoracic aorta, and if you see that, you've got to think, is the disease condition an acute on chronic presentation rather than pure acute? And the other thing is mosaic attenuation. Mosaic attenuation is a feature of chronic thromboembolic disease, not acute. Okay, so if you make sure that in every case of PE, you are looking at all of these components, you're not going to subject one of these patients for thrombolysis. Now, just going on to RV function, I want to mention MR is the gold standard, but if you do not have MR, of course, you just have to use echo. So these are two patients, the same patient, two different instances. The top deck is before they had their endarterectomy, and bottom deck is after they've had their endarterectomy. You can see that the sternum has been opened in the bottom lobe, and basic things such as the dilatation of the right heart, right ventricular hypertrophy, tricuspid regurgitation, paradoxical septal movements, all of these have reversed. What we do use MR in addition to all of this is, of course, to look at the vasculature, and you can see that following endarterectomy, there is the normal pulmonary vasculature on the bottom deck. Now, how do these tests perform compared to each other? This is by Sebastian Ley, and this is few years old now, but I have to mention that this institution in Germany is extremely biased towards CT and MRI. So their results may not be the same as other institutions, but I do like it because we are also in my institution biased towards CT and MR. But the bottom line is, if you know what you're looking for, CT is excellent for disease distribution. The only instance where digital subtraction angiography was better than CT and MR was when you looked at subsegmental vessels, which for all the things I've told you is not really a surprise, but time and time again, people put down CT because they say, we cannot see what you're talking about on CT, and I am very happy to tell them it's not the modality, it's the person who is looking at the modality that's the problem. Now, operability assessment, I'm not going to spend a lot of time on this because this is more of an art rather than a science, okay? I'm not going to be able to tell you who is operable, who is not operable, because it doesn't depend on one person's opinion. It's a multidisciplinary team approach. You need imaging, but it's just one part of the conundrum. You need to look at the experience of the center, the experience of the surgeon. They both are extremely important. And in the center's experience, you've got to take into account what kind of support do you have, what kind of intensive care support you have, anesthetic support you have. These are things that you cannot just put aside because it's not just a plumbing operation. There's more to it than that. One thing to say is, again, people ask me, what's proximal, what's distal on imaging? And it is not an imaging criteria. What constitutes proximal versus distal disease is the surgeon's experience. What may be distal for one surgeon may be proximal for the other. Okay, so it depends on the experience of the person who's doing it. Now, there are definitions for what is an expert center. So a PH expert center is one where they follow up 50 cases of thromboembolic disease per year, or they have at least 2 new referrals per year, or they should have done at least 20 PEAs, pulmonary endarterectomies, with a mortality rate of less than 10%. In the multidisciplinary team, it's important that you do involve a radiologist who's got a specialist interest in the disease. And the third point, I think, is the most important. The extent of the disease that your radiology colleagues are able to demonstrate to you must be commensurate with your pulmonary vascular resistance. If you've got a disconnect between the hemodynamics and what you can see on imaging, there is a real chance that what you're dealing with has got a substantial amount of small vessel disease, and that group of patients will not do well on surgery, and you need to take that on board before you decide to subject them to endarterectomy. Another important thing is, if you think they are inoperable in one center, please go on and ask a second person's opinion. And this is something the guidelines have said without any shame, because this is a rare disease, so not everyone will have the same opinion. And finally, from my point of view, if you see things that are not very typical on imaging, think about alternate diagnosis. Now, unlike yesterday's talks where they told you that CTPA is the gold standard for acute PE, for chronic thromboembolic disease, it is not the gold standard, because you will miss distal disease on CT. And remember, the place of CT in the diagnostic algorithm is very variable, and just like how you can have false positive VQ, you can have false positive CT, and an example of that is what I'm going to show you. Not all filling defects that you're going to see on CT is CTEPH, and there you go. This is something that most people will have in their collection, an expansile defect within the pulmonary artery. You do a VQ, there is no perfusion to the lung. You do an MR, there is very little going on in that right lung. But if you look at the PET scan, there is increased FDG uptake in that right pulmonary artery. This happens to be a case of pulmonary artery sarcoma. Incredibly rare, even rarer than CTEPH. But what you don't want to do is miss the diagnosis beforehand, because sometimes these patients also need to have debulking. So it's likely that they need to go for surgery, but this is not something that you want your surgeon to find on the table at the time of surgery. A bit of pre-warning would be good. Just a minute or so to touch on the new developments. You would have all heard of SPECT VQ. So all the VQ scans that I've shown you thus far is a planar VQ. It's a 2-dimensional VQ. SPECT VQ is a 3D VQ, where the pickup rate for your perfusion defects is going to go up because it's a 3-dimensional structure. Now, the thing is, if you don't have it, it's not a big deal. You can still make your diagnosis on the basis of planar imaging. But if you do have it, and a lot of nuclear medicine departments are moving towards SPECT VQ, for clinicians, it's a mindset. You just have to get your mind to start to train your mind to start to look at images like this. Planar VQ is bad enough. I can tell you SPECT VQ is tremendously difficult to get your mind around, but it's doable. Now, new developments in CT, essentially they are all aimed at reducing the radiation dose. Just to give you a rough idea, if you take chest X-ray as a currency, a VQ scan, a Q scan is about 50 to 100 chest X-rays. A CTPA, we are talking about 400 to 500 chest X-rays. So this is not a test that you want to keep repeating. You want to do it once and you want to get it right the first time. We do have radiation reduction strategies, which I don't want to bore you with, but just to say you've heard about one of them yesterday, the high pitch acquisition. There are a few other things that we can do, but I'm a great believer in doing the test properly the first time. So don't stinge on the radiation. If the patient needs it, give your clinicians a good quality study. The spectral CT is the so-called dual energy CT, just to show you an example. So this is where you're going to be able to look not just at the CT pulmonary angiogram, but you're also going to be able to look at the vascular bed. You get two kinds of pattern abnormalities in CTEPH, a match defect where the vessel is occluded and there is no perfusion, and a mismatch defect where the vessel is occluded but the perfusion can be preserved, and this is not surprisingly due to the bronchial circulation. Finally, this is four-dimensional MRI. This is not mainstream. A lot of places have just about started to use it. And what it is you're looking at the flow vortices within the pulmonary artery to see if you can identify latent pulmonary hypertension before it becomes evident on cardiopulmonary exercise test or echocardiography. The problem with this is it's not mainstream and the post-processing is quite tedious. So I would say in the next few years, this is where I see imaging going, because using this, we probably will be able to predict the pulmonary vascular resistance, but it's not something that we're going to do for you tomorrow. So right heart catheter is here to stay. So finally, my closing reflections are acute PE is not the same as chronic thromboembolic disease. There are differences at radiological level as well as pathological levels. It's very important, although you may not have a history of acute pulmonary embolism, you don't miss the diagnosis of chronic thromboembolic disease, but systematic follow-up after acute PE is incredibly important. Imaging plays a pivotal role in the diagnosis, and a multidisciplinary team approach is extremely important. Thank you very much.